Can you guys see?
It's gotten lost.
Now?
Still
Still
not.
blank.
Now?
Now we are good.
Which of the following side effect is not associated with insulin?
I think hyperkalemia. Insulin is even given to treat hyperkalemia, to manage hyperkalemia.
Okay, should we recall ourselves about the different types of insulin? I don't know.
Yeah, sure. We can recall and again, ladies and gentlemen, we are asking for active participation. Yes, so types of insulin. There's a ultra short acting. I think an example is Lispro.
Do you have a way of remembering it or something?
Pardon?
Like, something easier to remember.
Oh, I don't have a mnemonic. Maybe Nugal. I know Nugal was working on a mnemonic when I checked in with her in the afternoon.
So like, no, I don't. But you can
Ah,
search.
Okay, I'll share on the group. But I don't know. Okay. I think till then we can just start with what you are saying. We can start with the rapid acting
yeah, the rapid acting, yeah.
or ultra short. Yeah.
Yeah.
You said what the example was? Aspart.
Yeah, no, I said Lispro, but Aspart is also there, I think.
Lispro, aspart, and glucine.
Yeah, glulicine, yeah.
Do
True.
10 to 15 minutes, the onset. We need to remember the timings?
Kinda, yeah. So, just a question. Do we, because it's this ultra short acting, do we give them 15 minutes before the meals or 15 minutes after the meals or either? When should we give? When should they be administered?
I think they usually
Or same time?
15 minutes before a meal.
It's saying it can be injected at the start of a meal.
The start of a meal.
Or even that, yeah.
Ah, okay.
Then
Then we have the short acting.
mm,
The short acting. I only know about the regular insulin. One that is given IV, and it's the one we'll give for stuff like DKA.
uh-huh. Onset is 30 minutes. Injected before, given 15 to 30 minutes before meal.
Another point, so if we are just using short acting alone, like we are not combining with the other types, we have to give it 3 times a day. Before breakfast, midday, and evening. Before evening meal, like 15 minutes, as you said. 15 minutes or 30 minutes before the meal.
Sorry, Noor.
Oh, I was saying,
Mhm.
if we are just using the short acting alone,
Mhm.
we give it 3 times a day.
Oh.
Breakfast, lunch, and then supper.
Not the short acting, the rapid, the first one.
Then the intermediate. The NPH. Anything special about this one? The onset is 1 to 2 hours. And it can also be used to control glucose glucose levels between the meals, and also in combination with short acting.
Also,
Any-
I'm not sure if I'm right, but I think the intermediate is the one we were giving at bedtime.
I think that's the other one.
Long acting.
Long acting, yeah.
Yeah.
Another thing for intermediate, it's usually they have that protamine. So that's what causes a longer duration of action of the insulin.
Anything else? I know of Lantus as long acting. Any other?
It's also called glargine. Lantus, I think the brand name.
It's taken once daily.
Yeah. Another example is for the long acting is the detamere.
Mm.
So from the habit is like it's not a must that it's once daily. For some people, it can be taken twice daily based on the sugar, based on how well the sugars are controlled or uncontrolled. Yeah, so sometimes it can be taken twice a day.
Also, glargine should not be mixed with short-acting insulin preparations. The explanation it gives, or I was saying, glargine should not be mixed with short-acting insulin preparations because it's a clear solution with a pH of 4. So it remains stable at pH of 4, but precipitates at neutral pH. And now the other short-acting insulins are formulated. They are formulated at a neutral pH, so they can't go together. I don't know if the explanation makes sense.
It makes sense. It makes sense.
Yeah. So you can say it has a pH formulated at pH of 4, and the other ones are formulated at pH neutral, so they can't be mixed. Those are the short-acting insulins, such as regular, aspartate, and Dispro.
Anything else? Okay. Which of the following is not an alpha-2 adrenoreceptor agonist? Prazosin, clonidine, methyl-dopa, apraclonidine.
Oh, there, yeah.
Okay.
Prazosin, yeah.
Which receptor is it?
Alpha-1 antagonist.
We can remind ourselves what they are used for or anything.
Either resistant hypertension and BPH, benign prostatic hyperplasia or hypertrophy. But for BPH, we prefer, oh no, this is for the alpha-1 antagonist. Or for the alpha-2, it's just hypertension. And then methyl-dopa is usually the drug of choice for chronic hypertension in pregnancy. It's very safe for pregnancy.
Are alpha-2 also used for glaucoma? I'm not sure.
Maybe you can give the examples of alpha-1 antagonist, prazosin, terazosin, and doxazosin.
Mm-hmm.
Or as Kyle
And
said,
then-
they're using prostate. That one. I think it's called PPH.
Benign prostate hyperplasia. And then clonidine, I think, is also used for hot flushes for postmenopausal women.
And also an addition is for BPH, the specific drug is tamsulosin. It is also an alpha-1 antagonist, tamsulosin, for BPH.
Yeah, and then it's how it works for that is that it relaxes the smooth muscle, so it will decrease the resistance of urine outflow.
Actually, it does bladder, bladder muscle contraction, but the sphincter relaxation, so that you are able to void in case of prostate.
Sale paundi yake ni mkubwa. Mbona unafanana na Bella wa kwanza? Unafanana na Bella wa kwanza.
Which of the following is not an example of a pharmacokinetic drug-drug interaction? Effects of calcium-containing drugs on levels of tetracycline, co-administration of penicillin with probenecide to enhance its action, use of adrenaline to manage effects of histamine release, displacement of methotrexate from albumin binding sites by acetylsalicylic acid.
I think for that is the use of adrenaline to manage the effects of histamine release. So that was physiological antagonism, which is under pharmacodynamics.
Sorry, I didn't hear you.
Use of adrenaline to manage the effects of histamine release, because that's a physiological antagonism, which is and the pharmacodynamics when we're talking about agonist and antagonist.
Anything else?
Because looking at the other, like the effects of calcium containing drugs of the level of the tetracycline to affect the absorption. Then co-administration of penicillin with probenecid, this will affect elimination. Then displacement of methotrexate from albumin, this one will affect distribution. So A, B, and C is more than B. That is pharmacokinetics.
Intravenous general anesthetics include halothane, are highly hydrophilic, are good antidepressants, mainly act on the GABA receptors.
Halothane is an inhalation, no, it's not an IV.
Yeah.
And for them to function, they are not supposed to be androphilic. Actually, they should be androphobic in nature for the better activity. They shouldn't be antidepressant. They should even cause depression because they potentiate the action of GABA. So I would go with a D because they work towards potentiation of GABA.
Do we can recall the different what do you say, anesthetic drugs? Like between the local and the, I don't know, like talk about their features or something.
Maybe to talk a little about when you talk of anesthetics, we can have local anesthetics and general anesthetics. So on the local anesthetics, that's where we have the amines and the amide, sorry. And but these usually work by opening the sodium channels, not opening, sorry, blocking the sodium channels, because what they will do is like they'll block that nerve transmission, leading to the normal pain, normal transmission of impulse. But for the GA, they are divided into two. We have those for inducing and for the maintenance. Induction usually for the IVs like the Opento and Entomidate and things like propofol and ketamine. Then we maintain with inhalational such as halothane, nitrous oxide, sevoflurane, and the rest. But remember that some of the features in all this, some will have disadvantages against the others because you'll never get a GA agent, which is 100% getting the qualities of what you want. And in the GAs, there's something called MSC, that is minimum alveolar concentration. The lower the MSC, the better the action. And there's also that lipid diffusion ratio. When we look at some of them, they will have a very high MSC, something like nitrous oxide, making them not to be so good in anesthesia, but also they have the safety for someone who is not used in anesthetics like a student. When you look at something like allothin, it will have a greater side effect of hypothermia. And I know, remember, it's managed by things like dantrolene, but still it has an advantage that it does not cause, it is the best for people who are undergoing cardiac operations. So every anesthesia has an disadvantage and an advantage. That's why we cannot have one having all the qualities. And also, they can't work alone. They need some like adjuvants or adjuncts to facilitate their action, like muscle relaxants, such as succinylcholine and others, or something like atracurium. Yeah, that's what I can remember.
I think we can also add yeah, in the IV, we have the fast acting and the slow acting drugs. So the fast acting, you have propofol, and the slow acting drugs, you have benzodiazepines, dissociative anesthesia, and opioid analgesics like fentanyl. And as you mentioned, the mechanism of action is divided into 5. Like they can either like enhance the GABA effect on the GABA A receptors. Like example would be inhaled anesthetics, propofol, barbiturates, benzodiazepines, or they could block the nicotinic receptor subtypes and also activate potassium channels. Yeah.
Oh, that's true. Even something like ketamine works via the channel of NMDA, that is the N-methyl deaspartate channel. So it doesn't work via GABA per se. So thank you for that. Yeah.
It also enhances the glycine effect and also inhibits the synaptic proteins that decrease the neurotransmitter release. And also the factors that affect the minimum alveolar concentration could be blood solubility and the blood gas partition coefficient. And the toxicities could be hepatotoxicity, nephrotoxicity, or malignant hyperthermia. And also the differences between the general and the local anesthesia. So the general ones will act on the CNS, while local anesthetics will work on the peripheral nerves. The areas that are involved in general anesthesia is like the whole body, while for the local is just the restricted area. And you lose consciousness in general anesthesia. And it's usually preferred in major surgeries, while local is just preferred in minor surgeries. And the mechanism for local anesthetics is just blocking the nerve conduction by decreasing the sodium. Yeah, you mentioned that.
Yes, I think we also can mention about the stages in GA, and I think the first one is analgesia, whereby you just are losing pain, just little pain, but not everything, means the person is conscious. Then we have delirium. In delirium, this is where you have the eyeballs moving very fast. There's increase in respiration and the muscles are involved, there's tonic in muscle. Then we have the now the third stage of analgesia, the anesthesia, whereby the operation is done. At this, the movement of the eyeball reduces, the muscles are relaxed, and the breathing is constant. Then the fourth one, which we don't want and shouldn't be reached, is the respiratory depression. At this, we are almost losing the patient. And then maybe before I go off, I might take you back a little. Looking at the local anesthetics, most of them work almost at the same pH of the body. But I can't remember specifically the one which is so effective on suppurative wounds. I remember in suppurative wounds, they're already more of acidic in nature. I can't remember. If somebody remembers, please, you can help me out for local anesthetics.
I don't know about that. But I could remind us about the contraindications of spinal anesthesia, like it could cause hypotension, if the patient has hypotension, or mentally ill patients, children, and there could be sepsis at the injection site. So, yeah.
Please repeat that.
The contraindications to spinal anesthesia is hypotension or hypovolemia, or mentally ill patients, infants and children, and there could be sepsis at injection site. I don't know if anyone has to add anything.
Yes, maybe some of the complication of the spinal anesthesia. We know most of the time after someone has gone through a CS, we hear them complaining of headache. One of them is headache. Then you also experience hypotension. And also there's a possibility of this person presenting respiratory paralysis, also septic meningitis, or depending on the sterility or of the place where the operation was done from and how the process went on. Then you can also experience postoperative urinary retention. But looking at the headache, the reasons why they undergo headache is because of the, remember how we are putting the spinal anesthesia is via L2, L3, or L4, L3, L4. So we are putting this drug after getting out the CSF. So if the needle was too wide and a lot of CSF was taken out, then the patient will experience headache. And for the hypotension is because the local anesthesia in a way will cause the vasoconstriction of some of the fibers, leading to, at first there will be a transient like hypertension, but later this patient will have an hypotension due to the blockade of the sympathetic vasoconstriction activity. So first will be, we'll have headache because of the seepage of CSF, then we'll have hypotension because of the sympathetic inhibition of the vasoconstriction activity. Thank you. That's why most of the time in theaters, they will end up having things like ephedrine to ensure that the patient does not go to hypo.
Thank you. Okay, can we go to the next one? Which of the following is not an antipsychotic drug? Haloperidol, chlorpromazine, flufenazine, and venlafaxine. think I'll go for venlafaxine. It's a SSRI, right? I don't know what.
Yeah.
Yes, yes, it is. Yes,
Yeah.
it is SNRI, not
SNRI or
not
SN?
SSRI.
Sorry. SNRI. Also to remind ourselves about this antipsychotic drugs, they could be classified either as first generation or like with low potency and high potency. So in this, I think chlorpromazine is the low potency while the other two is high potency. They can be used to treat schizophrenia, and the mechanism of action is just basically that they're dopamine antagonists.
Yes, to maybe and a little addition on their mechanism of action, as we've seen, they're working on dopamine, and they are dopamine antagonist, yes. And because they are working via, remember the dopaminergic pathways, we usually have the 5 dopaminergic pathways. We have the mesolimbic, mesocortical. That's where now our being of psychosis comes in, all those neurological disorders like schizophrenia. Then the same pathways under the dopaminergic pathways, you have nigrostriatal pathway. That's when you talk of Parkinsonism. Because remember, in Parkinsonism, there's low levels of dopamine and increased levels of acetylcholine. So that's why you need the balancing by giving things like attain and at the same time giving the carbidopa. Then we have another pathway, the tuberoinfundibular pathway. This usually is more concerned with milk production. That is why most of the time you give somebody, a mother, bromocriptine, working on the dopa, because you don't want her to continue secretion of milk. Then we have I can't remember the other two, but there's also incidental hypothalamic pathway, usually more concerned with sexual behaviors and the habits. And also the other one is the fourth one, which I can't remember, is deals with eating behavior. So looking at the dopaminergic pathways, you can control Parkinsonism, we can control schizophrenia, can control psychosis. We can also control things like milk letdown, and yeah, thank you.
Could you please remind me which one I've missed out?
Okay, sorry. I wasn't aware that I was off. So the mesolimbic, mesocortical is one. So mesolimbic, mesocortical is one pathway. Then nigrostriatal is another pathway. Then tuberoinfundibular is the third one. The fifth one is incidental hypothalamic. This one deals with issues of sexual behaviors. Then the fifth one is let me remember. Medullary periventricular. Medullary periventricular, this is for eating disorders. or eating behaviors.
Sawa, thank you. Codeine is more potent than morphine, is a cough expectorant, may cause constipation, and is used to treat severe pain.
Constipation.
I think the answer would be C. And because remember, codeine is a constituent in cough syrup, specifically antitussive, not expectorant. And it is not potent than morphine because it has more OHs than morphine. If it was cocaine, not cocaine, but codeine would be more potent than morphine because it has two it is acetylated twice. So codeine, not cocaine, apologies. Codeine is not potent than morphine, but cocaine is potent than morphine.
But cocaine is more potent than
Yes, cocaine is more potent than morphine because it has two acetyl groups, which morphine doesn't have.
Is it cocaine or heroin? Because heroin is the one that is diacetyl morphine.
Thanks. It's heroin. Thank you. It's heroin, not cocaine. Sorry, it's heroin.
Yeah, because cocaine is on
Thank
its
you.
own class. Yeah.
It's heroin. Thank you. Thank you so much. Yeah.
Thank you. Anyone wants to add anything? Okay. ACE inhibitors cause all the following except angioedema, persistent cough, inhibition of kinin metabolism, and left myocardial hypertrophy.
Yeah, I think left myocardial hypertrophy.
Anyone wants to add anything? Could we just go through the antihypertensive drugs like a quick recap?
Yeah, so we can go through antihypertensives. Yeah.
Yeah.
Yeah. Just quickly, first line we have the diuretics, usually the thiazide diuretic, so hydrochlorothiazide, chlorthalidone. Yeah. And they act on the distal convoluted tubules and they cause hyponatremia, hypokalemia, and for thiazide diuretics, they can cause mild hypercalcemia, just mild. They don't increase calcium excretion, yeah. Then the CCBs, calcium channel blockers, usually now for hypertension, the dihydropyridine CCBs, commonly used amlodipine and nifedipine. So CCBs are essentially, they are vasodilators, and their side effects, 3 of them will have tachycardia, reflex tachycardia, secondly, headache because of the hypotension, and peripheral edema. Then the ACE inhibitors and the ARBs. The unique thing between ACE inhibitors and ARBs is that ACE inhibitors can cause cough, but ARBs do not cause this cough. So a patient on an ACE inhibitor complaining of chronic cough, you stop the ACE inhibitor or you switch it to the ARB. Then for the mechanism of action is obvious, inhibiting the angiotensin converting enzyme so that we don't make the angiotensin 2. Side effects, they've been listed here: angioedema, cough, bradykinin accumulation, hyperkalemia, yeah. Then I think those are the major ones. Then we go to the second line. We have the beta blockers. We have the cardioselective that you'd use for people with asthma or bronchospastic diseases such as COPD also, such as metoprolol, bisoprolol. Then the non-selective ones such as propranolol, labetalol. Side effects of beta blockers, those ones, they range from, they can trigger an asthma attack, bradycardia, depression, erectile dysfunction. Next, we've already talked about the alpha-1 antagonist, the quinaprazosin. Majorly, the issue with those ones is the postural hypertension. So you tell the patient to take the first dose while sitting or while going to bed, and advise them not to stand up real fast because of the postural hypertension. Yeah, the ones are just the quinaspironolactone. Those ones, they are the aldosterone antagonists. As a side effect, we'll have hyperkalemia, gynecomastia, menstrual irregularities, and also gastritis. For spironolactone, always advise the patient to take it with food. And if the patient has a history of peptic ulcers or is currently being treated for peptic ulcers, then spironolactone is a contraindication. Is contraindicated to it in such a patient.
Thank you, guys. Anybody wants to add anything?
Yeah, maybe an addition that you also have the direct vasodilators such as indralazine. You also have vasodilators which usually block the potassium channel, such as minoxidil. And on stem on diuretics, the diuretics will have the loop diuretics, thiazide, and the potassium sparing. And also we'll have the carbonic anhydrase, acetazolamide, and the stuff. Yeah, thank you.
Thank you. I think we can go to the next question. Eikonocytes are metabolites of arachidonate. They exclude leukotrienes. They are only formed in platelets and they inhibit lipooxygenase. Eikonocytes are basically three classes. They have the prostaglandins, leukotrienes, and thromboxanes.
Maybe to add a little, it's true. And remember, when you're talking of eicosanoids, you are talking of the class of autacoids. Whereby, when you talk of autacoids, these are self-healing. They are derived from within the cells, within our bodies, with the aim of protecting us. So they are divided into three. Generally, we have the amines, all biogenic amines. Whereby under biogenic amines, we talk of things like histamine, we talk of things like 5-HT. Yes, then we'll also have the lipids under the same, whereby on lipids is where you talk of eicosanoids. And as we've said, eicosanoids will be talking of prostaglandins, leukotrienes, and prostacyclins. And then we'll have the peptides, things like angiotensin, things like bladekinins. So all of those are under the same class of autacoids. But when you talk of eicosanoids, then you cannot do this without talking about the arachidonic acid, which is usually broken from the cell membrane by phospholipase A, if I've not forgotten A, yes. Then you follow the different pathways of thromboxanes, of prostaglandins, of leukotrienes, and the prostacyclins. Thank you.
Thank you. So what would be the answer?
I think they are metabolites of arachidonate. That's the right choice.
Yes, true, yes.
Does anyone want to add on anything to that? Okay. Hyperuricemia is managed by using sulfenpyrazone, captopril, hydrochlorothiazide, or salbutamol.
The sulfenpyrazone. Perhaps anyone with something to talk on gout. I think so far only less than 5 people have been talking. Let me see. Dr. Koech and Dr. Willie. Something about gout.
When we say it's mostly men who are predisposed to it. And also it's like as a result of hyperuricemia. Mama?
Yeah,
Yeah.
men because of habits, yeah. But also women, remember estrogen is a uricosuric. It promotes loss of uric acid in urine. So
yeah. And then the parts mostly affected are like is it like the joints? Yeah. And then what else did I want to say? Oh, there are some certain meals or lifestyles that when you participate in them that you might have a higher risk, like eating like fatty foods like nyama choma and drinking like beers and stuff.
Ah, yeah, nice. So yeah, alcohol, red meat, those are the obesity. And even some drugs such as even this hydrochlorothiazide, some of the anti-TB drugs, like pyrazinamide, ethambutol, they can cause that hyperuricemia.
And also some medical conditions like diabetes, heart or kidney diseases.
Ah, yeah. And also, yeah, chemotherapy. Remember, in chemotherapy, a lot of cancer cells are being destroyed, and that is essentially a lot of DNA is being destroyed, and uric acid is a product of DNA. So that's why you see some people, when being given chemo, they are given allopurinol as a prophylaxis against this hyperuricemia.
Then the complications could be joint disruptions or uric acid stones that could lead to nephropathy or renal failure.
Yeah.
Then if we can talk about the clinical presentations, they have that this was the spike things in this. I don't know.
Tophi.
Yeah. Yes, the tophi.
Yeah, the tophi, especially in the big toe.
Yes.
In the foot on the big toe, yeah. And the pain is usually so severe. So first line, what you'd give is an NSAID, something for the pain.
Yeah.
Before starting on the allopurinol.
Yes.
Yes, it's true, because remember, we also we can have acute. Sorry.
No, it's okay. You can continue.
I was also adding on something that we can have acute attack of a gout and chronic attack of gout. In acute attack of gout, we give the medication to ensure that you are not allowing the inflammatory responses or the immune cells coming into the active site, whereby there will be like accumulation of monocytes, neutrophils, making that environment unfavorable. So in acute gout, we give things like NSAIDs, as doctor has said, and also things like colchicine. But in chronic gout, then you want to manage the conversion of xanthine to hypoxanthine and to the uric acid, which is now the problem, because it's accumulation of urics in the form of mono salts, making those like sharp crystals in the joints. So in chronic, we use things like allopurinol, but you cannot really rely on allopurinol on acute attack of a gout. Thank you.
Just
can I also add?
that? Yes, you can add.
Oh, remember the gold standard test for gout is the synovial fluid test, where they take the synovial fluid and test and look for the uric crystals in the synovial fluid.
Yes. I wanted to just remind ourselves that NSAIDs we can't give to patients who have peptic ulcers or are taking anticoagulants or have renal diseases or uncontrolled hypertension or heart failure. And you could also give corticosteroids for first-line monotherapy for acute attacks.
Yes, still on addition, remember on the pathophysiology, usually we have in gout because there's an overproduction of uric acid, and there's also an undersecretion of uric acid. So we can also, and in humans, we don't have the uricase enzyme. the uricase enzyme is responsible for conversion of the uric acid into a more soluble form. I think the allantoin, I'm not so sure, but you don't have it. But essentially, when you want to, in the management of gout, drugs for that can be used. And if I remember the drug, I can't remember the drug now. If I remember, I'll let you know. But you want to make it more soluble for removal, and also want to ensure elimination of the urates. That's why also probenecid is also used, and sulfapyrazone, the one we've given an answer here. This is to ensure that we are eliminating the uric acid via the kidney. Thank you.
Mm. Mm. What else can we add? Oh, and the corticosteroid, you use it on as first line, depending on the number of joints that are affected. Then mainly you give prednisolone for that. Then you could use interleukin-1 inhibitors. An example would be anakinra or canakinumab. Yeah, and a combination therapy can also work if there are multiple joints that are affected in gout. So you could use colchicine plus NSAID or an oral corticosteroid. And maybe as non-pharmacological therapy, you could ask, you could advise the patient about regular exercise, reduce alcohol intake, maintain hydration and stuff.
Exercise might be counterproductive in this case. It might cause a rise in the uric.
Yeah.
Yeah, I remember the drug for making the uric acid more soluble is lasburicase, because also, as you said, on the class of xanthine oxidase inhibitors, we have allopurinol, and we also have febuxostat. I'm not so sure of the spelling, but I wanted to confirm the one for increasing the solubility is lasburicase. Thank you. Converts the uric acid to a more soluble form of allantoin. Thanks.
Yes, febuxostat. That one is a non-purine xanthine oxidase inhibitor, right?
Yes, yes.
Yes, please. Yes, please.
Should we remind ourselves of the common side effects? Just like for probenecid, the common would be hepatotoxicity. And also, you can't give febuxostat with a patient who has a history of allopurinol hypersensitivity syndrome. And for allopurinol, the major one is the maculopapular rash. But it doesn't occur to everyone, it's one to a few people. Yeah. I think we've covered, this was a intense discussion for gout. We can go to the next question, unless somebody has something to add.
I think we can move. If Nightwing has spoken, then we can move.
Okay, which of the following is the most potent diuretic? Chlorothiazide, furosemide, acetazolamide, or amiloride?
Furosemide.
Should we go to the next question?
Yeah, I think we've just covered diuretics when we were explaining hypertension. So
Yeah, that's why,
yeah,
yeah.
we can move.
Diabetes insipidus is caused by the deficiency of insulin, vasopressin, aldosterone, or renin.
Yeah, vasopressin, yeah.
Talk about diabetes. Mama.
How about the insipidus?
Mm.
Yeah, we can say a few things. Perhaps on my side, what I know is that the central diabetes insipidus and the nephrogenic diabetes insipidus. So for central diabetes insipidus, that one, the origin is the brain, or rather the pituitary, meaning the pituitary is the one that is not producing the ADH, the vasopressin. However, for nephrogenic diabetes insipidus, in this case, the pituitary is doing its job, it's producing the ADH, but the kidneys are the ones that are not responding to the ADH. Yeah.
Anyone else wants to add anything?
Okay, someone had said we talk about the central and nephrogenic again. So for diabetes insipidus, as from the question, it's a condition whereby generally, like the general definition, it means that there is a problem in your ADH production. That's the general definition. However, when you come to the nitty-gritties, we have two types of diabetes insipidus. We have the central diabetes insipidus and the nephrogenic diabetes insipidus. So for the central diabetes insipidus, this is whereby your posterior pituitary gland is not producing the ADH, the vasopressin. But now for the nephrogenic diabetes insipidus, your posterior pituitary gland, it's doing its job, it's producing the ADH, but your kidneys are the ones that are not responding to the ADH that is being produced. Hence the term nephrogenic.
So we can use desmopressin in central, right? Right.
Yeah.
Yes.
So yeah, for central, we'll use the desmopressin, but for the nephrogenic, ironically or paradoxically, we can use the thiazide diuretic hydrochlorothiazide. Why? Because long-term administration of a diuretic causes the body to adapt by absorbing more fluid, because we know ADH, essentially the function of ADH is to absorb water or to promote the absorption of water. Yeah, so we can give the thiazide, hydrochlorothiazide, so that after in the beginning it will cause more diuresis, but after a while it will cause the body to absorb more water than it would have. Dr. Berry has tweeted the symptoms of diabetes insipidus, the polyuria, polydipsia, yeah, excretion of large volumes of dilute urine, yeah.
Gaius, is there a particular reason why we use specifically thiazide diuretics and not like loop diuretics or any others?
I don't know. For that, I'm not sure. Maybe someone else can. But personally, I'm not so sure why specifically the thiazide.
You can also use amiloride, I think. So I think it's not just thiazide diuretics that you're using.
Yeah, by the way, yeah, even amiloride, yeah. Yeah, even amiloride can be used. Perhaps these are the ones that have been studied, but yeah. Let me send some picture to the group. Maybe it will help.
think we can move on to the next one. Which of the following is not used for the management of angina? Organic nitrates in nitroglycerin, beta-adrenergic receptor antagonist, calcium channel antagonists such as nifedipine, and angiotensin receptor antagonists.
I think here is the ARB that are not used for angina because the CCB is beta and nitrates, yeah, as Hiral taught us.
Guys, isn't it the beta blockers that are not used? Those are the ones that are contraindicated.
For angina,
Yes,
see, angina is ischemic heart disease. I thought beta blockers were the first line because they decrease contractility, hence decrease in oxygen demand.
because even ARBs are used.
Oh, ARBs are used for ischemic heart disease.
Yeah, either ACE inhibitors or ARBs.
Let me recheck because
Unless they're just talking about like,
I've assumed when they are saying angina, they are mostly referring to stable ischemic heart disease. Because otherwise, angina is just a symptom.
okay, then that would be okay then.
Yeah.
Yeah, then that would be okay.
Okay.
I think even I would go for D. But aren't beta blockers use like atenolol and propranolol? I'm not sure.
Yeah, vitamins are used. I think they're only contraindicated in the variant.
Yeah, for the presmental angina, because we said of the risk of vasoconstriction. Already in presmental, there's vasospasm, so we say we shouldn't give them for presmental.
Yeah, because I was going to ask in the.
And I think they're usually used with nitrate.
Yeah, definitely.
Okay, so we go to the next question.
Irregardless.
Just a minute, I see something on the chat. Which one of the following statements regarding management of hypertension is true? Vasodilators should never be used. Calcium channel blockers are effective because they cause contraction of arterial smooth muscles. Angiotensin ACE inhibitors are first-line agents in the treatment of hypertensive diabetic patients, and beta blockers can be used by asthmatic patients.
And go for C.
Yes, correct.
C, yeah.
Go with Hiral too.
So which drugs are not used by?
Would anyone know why B is wrong?
I think it's because of that last part. They cause contraction of arterial smooth muscles. They cause relaxation.
Aldosterone antagonists have a potent diuretic effect. They prevent potassium wasting. They should be avoided in heart failure, and they include carvedilol. Oh wait, before we go to this, Which ones are not used by asthmatic patients? Is it the non-selective or selective beta blockers?
The non-selective are not used.
Okay, thanks. Back to this question.
I think they prevent potassium wasting because they are potassium sparing diuretics. Because they are used for heart failure, they are not potent diuretics, and carvedilol is not one of them.
Anyone wants to add anything on this?
Someone said salbutamol or weight isn't salbutamol a beta blocker used for asthma management? Yes, but the difference is the beta blockers used for hypertension, they bind to beta 1. So when you use non-selective, they'll bind both to beta 1 and beta 2, exacerbating the effects of asthma patients. But salbutamol is just beta 2 agonist.
Thanks. Prokinetic gastrointestinal agents are used for the management of gastrointestinal reflux disease, duodenal ulcers, irritable bowel syndrome, and worm infestation.
Sophia told us yesterday that it's GAD.
Dias, what are prokinetic agents? It is like for medications for constipation or?
No, there are medications to promote movement
Motility.
of stuff from this, motility from the stomach, or rather from the lower esophageal sphincter into the intestines. So we have stuff like domperidone is a prokinetic, metoclopramide, also another one called etopride, is a prokinetic. So you usually find them in even combination with PPIs because they work together.
So in irritable bowel syndrome, isn't that also like you see, you want to increase the motility of the GIT, right? And irritable bowel syndrome is either constipation or diarrhea. Or
Yeah. Now you see irritable, it's either constipation predominant, diarrhea predominant, or mixed. So if it's constipation dependent, you want to give the bulk forming agents. If it's diarrhea dependent, there's usually that loperamide for the IBS, but we don't give the prokinetics for irritable bowel.
okay, thanks.
Yeah. Or rather, we typically give prokinetics for GAD. There may be a reason to give for IBS, but majorly it's for GAD.
Anyone wants to add anything on it? Anyone? Cholestyramine is a bulk forming laxative. It enhances the excretion of bile salts. It should be avoided by patients with jaundice and promotes the absorption of nutrients.
Enhances excretion of bile.
Anyone wants to talk about it? It's used to lower the cholesterol.
Maybe a few words just for, because for the cholestyramine, it falls under the bile acid sequestrants. And essentially what they do is that they will bind to bile and ensure bile is not reabsorbed to be recycled by the liver. Remember how this is significant is because bile is formed from cholesterol. So if you're losing bile every other time, it means you lose more of the cholesterol in the body to synthesize more and more bile. Hence they are used as anti-hyperlipidemic agents. Yeah. And these bile acid sequestrants, they are the only anti-hyperlipidemic agents safe in pregnancy if a woman in her reproductive age has an issue with cholesterol.
Okay, but I think we can also talk about the other hyperlipidemic drugs like statins.
Yeah. Statins,
So
I know.
They basically inhibit the conversion of HMG-CoA to mevalonate.
Yeah. They inhibit the enzyme HMG-CoA reductase. So
Yes.
they will inhibit the conversion of HMG to mevalonate. So, and that's enzyme, it's like the first step for the synthesis of cholesterol. So when you block that enzyme, you block the whole entire synthesis of cholesterol. It's the rate limiting reaction when you inhibit HMG-CoA reductase.
Yes. After that, maybe we can, after we do the classes, we can recall about the atherosclerosis.
Pardon?
The statins, we usually take statins at night to target the enzyme. Its production of cholesterol, I think, takes more night.
Yes. Also, niacin or nicotinic acid, which is a water-soluble B complex vitamin. Not to forget the fibric acid derivatives like fenofibrate. Anyone else wants to add anything?
Also,
Yeah. Shafigo, Shafigo.
I've seen that cholestyramine, that bile acid one, the one in the question, it's not used in combination with NSAIDs, especially diclofenac, because since this cholesterol something is inhibiting negatively, it leads to the blocking release of chemical messengers that will increase the effects of NSAIDs, like the fever, the pain, the inflammation will increase instead of lowering them. So you don't combine them with NSAIDs like diclofenac.
Also, I don't think you can use them with warfarin or digoxin or propranolol. I think maybe we can do the risk factors of hyperlipidemia, like family lifestyle, lack of sleep, pregnancy, genetics, unhealthy eating, definitely. And if you are told to give an non-pharmacological treatment, you just ask the patients to reduce the intake of cholesterol, reduce the sources of saturated fat, and they should consume more vegetables, fruits, increase the supplementary intake of fish oil. And yeah.
Also, you can say, you can remind ourselves that the bile acid sequestrants, the cholestyramine, they will cause impaired absorption of fat soluble vitamins because of the interfering with the bile acids, the likes of vitamin A, D, E, and vitamin K.
Yes.
Yeah. Excellent. Also, one last thing on this, we mentioned on fibrates, and the fibrates and the statins should not be co-administered because of the risk of myopathy. So yeah, statins and fibrates, it's a no. Bile acid sequestrants and NSAIDs, it's a no. Yeah. I think we can, we can go to someone can take us through formation of an atherosclerotic plaque.
Formation of what?
Atherosclerosis.
Sclerotic plaque.
Okay. Atherosclerosis, it's formed when there's increase. A minute, wait.
It's just an inflammatory process, and there's a formation of the plaque which ruptures the artery and then causes a block. I know that much. I don't know. I don't.
Yeah.
But
It's
that's the
actually
summary.
initiated.
It just causes. It just blocks. the
Yeah, it's
arterial
initiated.
walls.
This is where the LDLs get oxidized, and they form the oxidized LDLs, and then there's macrophages. Then they build up and they form the foam cells.
Yeah, it's like when there is initiation of endothelium activities due to accumulation of lipids like LDLs. So they trigger the vessels narrowing and inflammatory pathways. So all the like macrophages and everything will come to the site. So it will form a plague, and the plague will lead to narrowing of the blood vessels. It happens between, we say, intima and what?
And media.
Is it the media?
Yeah, so it leads the narrowing of the blood vessels, and eventually it can rupture and form thromboembolism somewhere else, or it can lead to further complications.
Let me ask you guys. We're saying cholesterol contributes to condition of hypercholesteremia. Is it the dietary cholesterol, or is it the one that the body is synthesizing? So is a hypercholesteremia a condition of maybe deficiency or a fault within the metabolism of cholesterol, the dietary one, or the one that the body produces?
I think Chai, I think you know the answer. You can tell us.
I don't know.
Yeah. Yeah, you can save us the time. But my assumption would be it's from diet, because lifestyle, we say lifestyle, the sedentary lifestyle and consumption of these fatty foods are one of the main contributors. But I'd say there's an aspect of diet and an aspect of metabolism, both contributing. But that's just my assumption, and because I know the type of questions you ask, they usually have both answers.
I continue, Amma.
Irregardless, Shafi, irregardless.
Yes, we can do the last question. Or you guys want to continue? Let's finish this one. Which one of the following antibiotics is not useful for the management of infections caused by anaerobes such as Bacterius fragilis, clindamycin, metronidazole, imipenem, and kanamycin?
Someone said kanamycin.
Yeah, the answer is kanamycin.
Because fragiles are resistant to kanamycin.
Oh, okay.
How? How though? Explain, please.
Kanamycin is used for aerobic gram-negative, and fragilis is anaerobic.
Oh.
I don't know if you can go with that reason.
That is reason enough, Doctor. That is reason enough.
Hiya, good night.
Okay, just before we do good night, we can just talk a bit about this bacteria. It's anaerobic, it's a gram-negative. What are the diseases it causes diarrhea?
It causes pelvic inflammatory disease.
Sorry?
One of the diseases it's caused is the pelvic inflammatory disease, PID.
I think my internet is bad. I can't hear you. It's unstable.
She said it causes pelvic inflammatory disease.
Anything else to add before we do good night?
That bacteroides is also part of the oral normal flora.
Yeah, it's part of the normal microbial of the human colon. The disruption of the mucal surface, either by inflammation, trauma, or surgery, and a spread of the bacteria to the bloodstream or surrounding tissues result in clinically significant infections. So one of the infections it leads, as Fatima said, is pelvic inflammatory disease. And I can see here it rarely causes also endocarditis and septic arthritis, meningitis, but those are rarely.
Okay. Anything else?
Fatima said it also causes peritonias and abscesses that's associated with abnormal trauma or surgery.
So, let me add that. Are we having a class tomorrow?
Bright and early, Dr. Patel, bright and early. Tomorrow we are celebrating Mashujaa Day.
By the way, I have an issue tomorrow because I will cover renal anatomy and physiology in that like in 30 minutes. So someone from you guys can volunteer, and then we start with the disorders. We just make it as a discussion, and then we discuss the disorders.
Hey guys, good
Yeah.
night.
Good night too.
Good night.